Topic is kidney stap. Presenting the case, it's a case of Mrs. D, a 37-year-old housewife from West Bengal, presented with complaints of lower backache for 2 months and low-grade fever for 2 months. History of presenting illness. She was apparently well until 2 months back when she had lower backache and had radiating pain to the left lower limb, like electric current-like sensation is what she says. There was progressive worsening of the flexion movement with significant restriction of the movement. History-wise, there was no history of trauma or any sensory or motor deficits. There was no early morning stiffness. There was no involvement of any other joints. She had no oral ulcers, rash, photosensitivity, skin tightening, or Reynolds phenomenon. She had normal bladder and bowel habits. Fever-wise, it was intermittent without chills and rigors. No diurnal variations, not associated with any cough, vomiting, loose stool, headache, seizures, or altered mental status. Past history-wise, she had no known comorbidities. She was not on any regular medications. On presentation examinations, her vitals pulse was 96 per minute, BP was 160/90. With general examination positive finding wise, pallor was present with mild bilateral pitting edema. And the systemic examination wise, higher mental functions was normal, GCS was normal, cranial nerve examination was normal. Only positive finding was left-sided power in the lower limb was 4/5. Bilateral plantars was plexus, and all deep renal reflexes were positive. There was no meningeal signs. Cerebellar signs could not be assessed for the lower limb, but upper limb was normal. Rest of the systemic examination was normal. So the differential we considered regarding this presentation was first we considered as an infectious cause, which could be localizing to the spinal cord, could be a vertebral osteomyelitis or discitis, could be a spinal epidural abscess, could be a septic arthritis of the sacroiliac joints. Second, we consider was inflammatory condition like ankylosing spondylitis or reactive arthritis, malignancies like multiple myeloma. Baseline investigation showed a HP of 8.4 with an MCV of 72.3. The total count of 14,100. She had an elevated urea creat of 2.09. And other positive findings were urine routine showed an RBC of 1251 with a WBC of 167 with a protein of 3+. The bloodborne virus screening was negative. Because of her presenting complaints, we went ahead and did an MRI whole spine screening, which showed an infective spondylodiscitis at the level of L1 and S1, an epidural abscess and soft tissue compression of root S1, and small paravertebral abscess at L5 to S2 level. Serum electrophoresis showed there was a general increase in gamma region. Then we sent off the blood culture along with the pus culture from the paravertebral abscess with urine culture, and everything grew MRSA. And CT guided biopsy was done, which showed chronic osteomyelitis. So on the culture proven MRSA, we started empirically on vancomycin, and after sensitivity, we switched to linezolid, and we consulted ID, and we changed the medicine to renal adjusted teicoplanin. I want to focus more on the AKI. A baseline period previously reports were saying 1.2, but it spiked up to 3.2. So we considered the causes as prerenal could be dehydration, but she was adequately hydrated in the wards. Renal cause could be glomerular cause, which could be infectious-related glomerular nephritis. Tubular cause causing ischemic ATN or nephrotoxic ATN. Interstitial cause, which could be infection-related or drug-induced. And all our antibiotics were renal-adjusted dose, or some post-renal cause, which could be urinary tract obstruction. Ultrasound was done, which showed no positive obstructive cause. There was no hydronephrosis, but there was grade 2 renal parenchymal change. In view of urine showing 3+ proteins, we went ahead and sent a 24 hours urine protein creat ratio, which showed a urine protein of 5 grams, more than 5 grams, with a 24-hour urine protein creat ratio of 10. So for the same, we consulted nephrology for a biopsy. But first impression which they gave was MPGN or an IgA predominant IRGN. But after the culture grew MRSA, they updated the consult. Probably it could be an IgA predominant IRGN in view of staphylococcus bloodstream infections with disseminated paravertebral and epidural abscess. So they advised to withhold the biopsy till the active infection is Okay, so I want to talk more about this IgA predominant IRGN. I have taken an article from Indian Journal of Nephrology, which is an India-based study of a single center experience. They have taken a 12 case series. They have in the hospital they have taken case which were proven diagnosis of IgA predominant IRGN. The criteria for diagnosis which they have taken is clinical or laboratory evidence of infection preceding or at the onset of glomerulonephritis, depressed serum complements, ECP and exudative glomerulonephritis, C3 dominant or codominant glomerular IF staining, hump-shaped subepithelial deposits on electron microscope. But for this particular study, they follow the same 5 criteria, just the 4th criteria, which is C3 dominant, they changed it to IgA dominant and codominant immunofluorescence is needed for a diagnosis. So this is the clinical and laboratory comparison of the 12 patients. On the right side is the mean average which is taken. The mean average which people presented was around 52 years with the plus minus of 21 years. The male to female ratio was 2:1. And all the most common organisms which was having IgA predominant IRGN was MRSA. Source was different, but the most common source was more than 50% was skin. They all had proteinuria, all presented with nephrotic range proteinuria, that is more than 92% presented with nephrotic range proteinuria, with 33% presented with gross hematuria. And the mean creatinine of those people at presentation was 5.65 with a low C3 of 92%. The left side is what our patient had. She was 34-year-old female who grew MRSA with probable source UTI or vertebral abscess with a UPCR ratio of 10, and she had gross hematuria with a creat of 3.5 and C3C41 131 and 61. So we couldn't do the biopsy, so we don't have the results of the immunofluorescence and other things. Then they compared their own study with previous studies which was there, which all showed how the male to female number of patients, the mean age, male to female ratio, and if there is any comorbidities, the common site of infection, and the presentation wise nephrotic syndrome and hypercomplementemia. So most of the patients progress to end stage renal disease. And so I want to talk about my take home message from this is IgA. We have to remember IgA dominant infectious glomerulonephritis is a distinct morphology of IRGN. The most common organisms with MRSA, and the diagnostic criteria for IRGN, IgA dominant, predominant IRGN. Okay.
This MRI finding you just shown. L1 to S1.
L5 to S1.
Thank you for that presentation. In all this literature review that you found, how common is this particular entity, IgA dominant IRGN?
I don't know, person is not very common, but it's because of
No, you have to give us a number. Because they're going to take home message saying you have to do all these tests in those people who come with IgA. That's why I'm asking. Okay, then the slides are a little busy. We can't concentrate on what to do. You have to make sure, and when you're presenting also, you all don't need to say HB is 8.4, MCV is 72.3. You can just say hypochromic microcytic or something like that. It showed up with nominal transaminitis. Don't just constrict anything. All fonts should be very visible. Only 6 lines, six words per line, please. And please make your things more comprehensive. How was the patient at the end of all this wonderful
She's still under us. She's getting IV antibiotics for the MRSA. After
how many days is she finished now?
She has finished almost 10 days now.
10 days. And how is her creat now?
The latest creat was on third, it was 1.8.
Third? Okay, it is
Yes.
1.8. And urine output is adequate. Fever has come down?
Yes. See, this low grade fever, but now she's
down. And she's eating properly. And urine output is adequate?
Yes, ma'am. She's able to ambulate now also.
Any other questions? Thank you, Nisheet.